share with you one of my very interesting case with Dr. Brian Chua about a um, an, um, a syndrome named Urret Zavalia. This is a 45-year-old female with a history of her right eye phaco. And just 2 days after being discharged from the hospital, she had to come back to the emergency department because of the severe eye pain in the operated side. So she presented with microcystic corneal edema, anterior chamber deep and quiet, dilated iris with center PCIOL and the inferior haptic visualized with clear fundus view. And the starting pressure was 62 after 3 rounds of Comigan, drusamine, and iopidine, and 2 rounds of Diamox, 500 milligram, the pressure down to 54. And the impressions were whether there was some retained viscoelastic or this was an intermittent angle closure. And of course, the PCIOL was well centered and no subluxation. So the AC tap was performed 2 times with some additional Diamox, 250 milligram, and all maximal glaucoma drops. Then the pressure down to 7. But just shortly after that, pressure increased to 35. And the second tap was carried out with mannitol 20%, 60 gram over 30 minutes infusion. Then the pressure reduced to 13. Finally, the patient was readmitted to the hospital. The first day after being admitted, the pressure was 32, and then gradually went down to 20 in the afternoon, and the patient felt better. She was on Simbrinza Trusov, Timolol Diamox, and 2 AC tap with mannitol infusion before her second admission. And on the first day, her right eye looks better with mild corneal edema. 1+ cell with vortex noticed, means that no retained viscoelastic, and the pupil dilated on atropine. On gonioscopy, the angle closure with the iris configuration is angle closure, and PCIOL stable. Then atropine was ceased, then switched to pilocarpine 2%. Day 2, post-op, the pressure 12, and the AC looked deep centrally and quiet with iris roll and causing angle closure and stable BCLL. So Diamox stop, and all glaucoma drops continue. Day 3, the pressure well controlled. At 9, the AC deep and quiet, pupil dilated, angle closed. So she was discharged with Simbrinza, Timolol, Travatan, pilocarpine 2%. And 2 weeks after being discharged, the pressure is still 9 on all drops, and pilocarpine 2%. You can have a look here. This is the pupil, the AC, and the PCIOL, the right eye. This is the left eye, non-operated eye. And finally, she was diagnosed with a syndrome named Urret Zavalia, in which the pupil fixed and dilated. Here is the cassia anterior segment images of the patient ACD. dilated pupil, open angle in the operated eye and the fellow eye. So Urret Zavalia is a syndrome described so many years ago in other appearance of a fixed and dilated pupil following some intraocular operations or keratoplasty. The incidence of this syndrome varies from study to study. It could be 0% or up to 17%. And normally it happened unilateral despite bilateral surgery. But they found that up to 14% unilateral Urret Zavalia syndrome then present in both eyes. Some risk factors are the elevation of the intraocular pressure, the usage of atropine or other mydriatic agents, and keratoconus as a predisposing factor of this syndrome, retain viscoelastic material as gas bubble using for keratoplasty and AC inflammation. And the pathogenesis of this syndrome was hypothesized for the iris, atrophy, and sphincter ischemia, and the increase of intraocular pressure, and all these two factors contribute to the occurrence of Urret Zavalia syndrome. And this syndrome happened after several ocular surgeries. The most common one is penetrating keratoplasty and DALK and some paper describe Urret Zavalia syndromes in cataract surgeries and even glaucoma surgery. To prevent this syndrome preoperatively, we can give some mannitol infusion. During the surgery, we need to maintain the anterior chamber, avoid any trauma to the iris. And some authors, they propose the prophylaxis peripheral iridotomy in penetrating keratoplasty to prevent UZS. And after the surgery, we have to clear meticulously all viscoelastic material, and we have to be careful with the size of the bubble or gas in the AC after surgeries like DSEC. And during post-op period, we need to control pressure, and we should avoid overuse of mydriatic agents. And we can treat this syndrome by dealing with causes like washing AC if we still see some retained viscoelastic, or if there is an iris corneal touch, we have to break that touch, and we keep the patient on pilocarpine. And that's my presentation. Thank you for listening.